Okay, we're going to continue on here. I hope you all had a good break and enjoyed the music of Don and Lewis. Our next speaker is Dr. Sudhakar Satti, and I almost feel like I should be able to introduce Sudhakar in my sleep since he's spoken so many times at our conference. And he's perennially a favorite speaker. I think you're in for a real treat. Sudhakar received his Bachelor of Science in Biology at Gannon University and got his MD at the Medical College of Pennsylvania. He did his internship in internal medicine at Drexel University and then did his residency in diagnostic radiology also at Drexel, and then completed fellowships in both neuroradiology and interventional neuroradiology and endovascular neurosurgery at the University of Pennsylvania. Sudhakar is currently the Associate Director of Interventional neurosurgery here at Christiana Care, and is going to speak to us today about carotid artery disease.
Thanks a lot. Thanks so much, guys. I'm so pleased people came back from the break. It's always scary after a long break if people are going to show. So I'm going to do a little quick summary of carotid artery disease, and I was trying to focus on it being very helpful and practical in terms of managing patients with carotid artery disease. And I think the challenging part of carotid artery disease, it's a moving target. So, in the short career I've had over the last 15 years from med school to now, the guidelines continually change. And there's always this question, should we medically manage patients? Should they undergo carotid endarterectomy, or should we have carotid artery stenting? And so it's a moving target because the medical therapy continues to get better and better and better. So what is it and why is it important? So as you guys know, here's the carotid artery. It's on the left side of your neck, and basically atherosclerotic disease develops over the course of a lifetime. You start having this kind of atherosclerotic disease start developing in your 20s and early 30s, so most of us in the room already have this going on, and this narrowing is an issue because clots can, either the plaque can break, and a piece of the clot can break off and go to the brain and cause a blockage, or the whole blood vessel can get blocked. So how are we traditionally been treating carotid artery disease? And this is the carotid endarterectomy and kind of what it looks like. So there's a bunch of clamps, and this is the distal end where I have this blue markers, the proximal end, and we're actually harvesting the plaque out of it. So I tried to break this down into either asymptomatic and symptomatic. So if you're seeing patients or you have a patient that has asymptomatic greater than 50% stenosis, the prevalence is low in the general population. So I was thinking, should we be screening people of carotid artery stenosis? Probably not. So if you don't have symptoms of TIAs or ipsilateral stroke, then general screening is probably not worthwhile in most patients, but age is the most important risk factor, and screening is generally recommended. So if you break these patients down by age, so if we looked at this meta-analysis of over 20,000 people, and we look for stenosis of greater than 50% in asymptomatic patients, if you're less than 50, your chance of having atherosclerotic disease is less than 1%, less than even 0.2%, and the first is males and females. So women less than 50% are almost unheard of to have atherosclerotic disease. So if they have narrowing, it's maybe from something else. But once you're greater than or equal to 80, now the incidence is 7.5 and 5%. So about 5 to 7% of patients over 80 are going to have stenosis. So looking for it in all patients may not be beneficial. So the thing I always taught is, put your stethoscope on their neck and see if you can hear carotid bruit. And how sensitive and specific is that? Meaning, if you put your stethoscope on their neck and they have narrowing, how likely are you going to hear something? And so the sensitivity is about 50%. So if they have significant narrowing of 70 to 99%, 50-50, you're actually going to be able to hear something. Now, how specific is that? That means if you do hear something, does that mean that there is narrowing or not? And if you do hear something, it's 80% plus specific. So it's worthwhile probably throw your stethoscope on their neck, and 50-50, you're going to hear something. And if you do, it's helpful. But if you don't, that does not mean they don't have it. So what about an imaging approach? So you're worried about this patient. They have other risk factors, coronary artery disease, peripheral vascular disease. They're going to have a CABG, and you want to see whether they are going to need to have something done or the degree of stenosis. So the workhorse is the Carotid Duplex ultrasound. So basically look at the ultrasound of the neck. CT angiography is generally done more and more commonly, and MR angiography, and I'm very briefly touch on the advantages and disadvantages. So carotid duplex ultrasound, it will detect a focal increase in blood flow velocity. What does that mean? They stick the probe on the patient's neck, and they're measuring the speed of blood flow. And wherever the blood vessel gets narrow, the blood flow goes faster. So then they have a chart in each lab, and they basically look at this, measure the speed, and they look at the chart, and then they extrapolate the degree of stenosis. It's very operator dependent and requires a tremendous amount of skill, so you want to go to a center that has an accredited vascular lab so that they're maintaining appropriate levels. So how does this compare to what we used to do 50 years ago, which is actually do a catheter-based angiogram, and it's about 90% sensitive for detecting significant disease, and it's about 85% specific. So pretty darn good. But this is not 100%. So if you have an ultrasound and you think you don't agree with the report or whatever, then consider a second imaging modality. So this is kind of what they're doing. When you look at the pictures on your PACS or you get the pictures at your office, this line represents the angle of the transducer, and these bars are measuring the speed of blood flow through that blood vessel, and you create this waveform, and basically this dot represents the peak systolic flow, meaning how fast is blood flowing, and this patient has a pretty significant area of stenosis based on the velocity. So that's basically what they're doing. If you are not sure, or you get somebody on the borderline, maybe a CT angiogram may be useful. Downside is radiation. They need contrast. The upside is you can get 3D reconstructions, get very accurate pictures of what's going on with the blood vessel, especially in the setting of dissections. It's useful if ultrasound is not reliable. Patients who have extreme tortuosity, kinking, prior scarring, calcification, a very short neck, or a very high bifurcation, this would be very helpful. Sensitivity is still only about 75%, but when you do find narrowing, it's extremely specific. So when I say 3D reconstructions, what do I like about a CT angiogram? You can evaluate the entire blood vessel, so let's say the left common, from where it starts on the aorta, and then we can look at axial imaging, meaning we can actually cut it in slices, like you're getting little slices of pepperoni, and here's the actual opening of the blood vessel, and this is all plaque, so pretty significant degree of narrowing. And then for surgical planning or endovascular treatment, these are the kind of pictures that we can generate and measure the devices we're going to put in there, figure out how tortuous the blood vessel is. MR angiography with and without contrast is very helpful. It's nice because it's less operator dependent. However, it's more expensive and time consuming. Time of flight MRA is a fancy way of saying no contrast. Contrast-enhanced MRA requires contrast, but there's no radiation with either of these exams. It's very accurate for high-grade stenosis and occlusion. So if you have a high-grade narrowing, it's very accurate. If it's occluded, it's very accurate. But if it's moderate stenosis, the degree of narrowing is harder to measure. So maybe ultrasound is a good way to start, and if you have a question, then use MR angiography. Sensitivity is high, 91 to 99% for narrowing, stenosis and occlusion, and very high specificity. So now you have these patients, they have carotid disease. How do they present? Are they going to be asymptomatic or symptomatic? So asymptomatic patients are going to have no recent history of ipsilateral carotid territory ischemia, so they don't have any symptoms of strokes or TIAs in that territory. You cannot consider vertigo, lightheadedness, and syncope generally as a disease of the carotid artery. So when people say they had vertigo and we look for their carotids and they have 80% left internal carotid artery stenosis, so they got a carotid endarterectomy. Maybe they did need one, but that's generally not considered a symptomatic lesion, although it is sometimes a little flexible in some people's minds. Symptomatic means that you have a focal neurologic deficit, TIA or ischemic stroke, ipsilateral to the carotid artery. So it has to actually, correspond. What do I mean by recent? It's been defined as less than 6 months, and some people would say 4 to 6 months. And some people would say less than 6 weeks, but these are the American Heart Association guidelines that are going to say that somebody was a symptomatic lesion, it should be less than 6 months. So I just highlighted this, and this is the take-home. I'm so sad about interventional and surgery in general. It's just getting replaced by all this medicine, but no, I'm just kidding. All right, so for medical, you want all these patients to be on a statin. You want to think about antiplatelet agents, either aspirin or if you have an indication, coronary artery disease, peripheral vascular disease, lifelong dual antiplatelet therapy, and we really want to focus on the secondary prevention. It's too much to fit on this slide, but so that's the key. Statins, antiplatelet agents, so they should be on a statin, and aspirin, and secondary prevention. And the secondary prevention, key things we want to think about are controlling their hypertension. They just came out with a whole new set of guidelines for hypertension management. Used to be 140 and 130 if you were not diabetic, and now it's just less than 150 unless they're already initiated. So just something to look into. Aggressive treatment of their diabetes. We're looking at their hemoglobin A1Cs and smoking cessation. We have quite a resource here in Delaware with a quit line, so we should refer people to that. Okay, let's see. Lifestyle modification, so easy to write. Lifestyle modification counseling was provided, but it takes a lot of time and effort in terms of smoking cessation, limiting alcohol consumption to less than 2 drinks a day, ideally 1 for women and less than 2 for men. Weight control, regular aerobic physical activity. It's very hard. I was trying to come up with all these things for that for patients, and now I just say if you break a sweat, that's probably an aerobic activity. And you do that 5 days a week, I would be very pleased. You can't put on 4 coats and do that, but they get what I'm saying. A Mediterranean diet. Asymptomatic patients. So you get these patients, they have no symptoms, and unfortunately, I say unfortunately, jokingly, we find this narrowing. Now, what do you do with these asymptomatic patients with 60 to 99%? Should we do surgery for these patients? What about the difference between men and women? American Heart Association guidelines, and what we're trying to do is balance the risk of their disease, this is what we're doing all the time, versus the risk of the treatment. And we're trying to figure out, is the risk of the disease worse than the risk of the treatment? And so carotid endarterectomy greater than 70% stenosis, the risk of perioperative stroke, MI, infarction, and death should be less than 3% for the center and the individual surgeon. So unfortunately, that's something that people have to kind of keep track of, and that's why it's important to maintain that credentialing of the institution and the physicians to shoot for that less than 3%. Generally, aspirin is initiated prior to a carotid endarterectomy, 81 to 325 milligrams, at least 3 months post-op. Greater than 3 months for most patients to prevent cardiovascular disease. And again, if the patient has any history of TIAs, ischemic stroke, lacuna or cryptogenic type strokes, or peripheral vascular disease lifelong, aspirin may be reasonable. So what are we doing here when we do carotid endarterectomy? So this is the patient's neck, and this is the line that we're thinking about in an incision. And so the incision is made. This can be done under local anesthesia with either nerve block or sedation or general anesthesia, but a lot of times can be done with local anesthesia. So they're trying to identify basically 3 very important structures: the vein, the artery, and the nerves. So this is what happens when, and this is important to think about when there's a complication or an adverse event associated with carotid endarterectomy. Where are the clamps placed? So a clamp is placed, if I'm going to fix my leaking toilet at home, my kid puts 4 rolls of toilet paper in there, I have to turn off the water first. So that's basically what they're doing here. Putting a clamp on the internal, external, and the common carotid artery. An incision is made in the internal, the common carotid artery, and some patients that are shunted. So they'll do actually neurologic monitoring during the case, and if there's a change in the neurologic monitoring, they're actually doing a temporary bypass. So that's what a bypass looks like. They just put a plastic tube distal, plastic tube proximal, and they're usually sewn or clamped into place. The plaque is actually physically removed, like opening up a sausage skin and pulling out the actual sausage meat. That's what it kind of looks like. And then in some patients, they can just sew the blood vessel back shut. In some patients, you could imagine you can't get back to the same place you were, so they'll put an interposition graft, or like this little porcine graft. So that's what a patch graft is. So the complexity of the procedure can increase from just the clamping to a surgical bypass to a patch graft, and whether it's a local or general anesthetic. So the complexity can change depending on what we're doing. So you can imagine asymptomatic patients that have the more complex procedures may be at higher risk.